we are ready to educate you and, of course, definitely give you some tips on endometriosis. And also, we talk about subfertility today, and we have the best person to explain everything for us. Dr. Elias Tsakos is here. He will be right here with us, so don't worry.
Yeah. Hi, everyone.
Thank you so much for joining, Dr. Tsakos. How are you? I know you've been busy, and I'm glad that we are all here and are ready to...
I'm fabulous. I'm really well. I'm just getting ready for a wonderful trip to Serbia, Belgrade tomorrow for an amazing fertility event. And then next week, it's ESHRE. It's the European Society of Human Reproduction Conference. Looking forward to scientific meetings, seeing old friends, seeing you, Caroline, and the European Society people. So yeah, I couldn't be happier. So please, let's kick off.
Definitely. Thank you everyone for joining. We will definitely start with the presentation. Just let me remind everyone that after the presentation, all the questions will be answered. So please just type those in the chat, and Dr. Tsakos will definitely answer them for you. And I think we can start with our presentation. So yeah, let's go for it. Okay, thank you.
Endometriosis and fertility. I will keep it short and sweet, about 20 minutes, and then we can have another 20 minutes of questions if that's okay. But if any of you hasn't got the time or won't have the time to discuss, feel free to send an email at the end of the event to info@embryoclinic.eu. I've actually typed it in the comments. So I can provide you with any additional information you may wish to have. Now, this is one of my favorite topics, and this is simply because it's a wonderful bridge of my two passions. One of them is fertility, of course, and the other is surgery, reproductive surgery, and endometriosis represents the most common etiology, the most common indication for reproductive surgery. So I'm hoping that I should be able to give you my viewpoint, because this may be a little bit different to what the majority of fertility doctors or endometriosis specialists have, because nowadays most of those amazing people, they're either trained in fertility or in endometriosis, and they have their own viewpoint. Whereas in our team, we're privileged to have this dual horizon, looking at our patients from both points of view. And of course, this is part of the multidisciplinary team we are privileged to offer. So I will give you, most of you, if you do have endometriosis, you will know all that. So I will be very quick in going through it, the overview, the fertility associations, the effect on the outcomes, and the treatment options. So endometriosis, more or less everybody knows what that is. It's not endometrial tissue. It's endometrial-like tissue, which instead of being just where it should be, it lies in different various positions. And of course, this causes inflammation and fibrosis. It's a very strange disease. It's a disease that can affect a huge amount of women, and it may have a different manifestation and different way of presenting itself. So it could either present with endometrioma or with some subtypes of endometriosis. 20 to 45% of endometriosis cases have endometriomas, which are particular cysts on the ovaries, and it could be multiple, it could be single, and of course it causes inflammation and distortion of the anatomy. The prevalence is elusive. Some people mention millions of women over the world. What we know only too well is that it affects about 10% of women in the general population, and that every year around 50 women in 100,000 are diagnosed with endometriosis. It's commoner to present itself during the reproductive age, and that is the 30 to 40 years of age group, as you can see here, although it's not unlikely to have this presentation much earlier, even in the teenage years or even in the prepubertal years, and it's not unlikely that this may be evident even after the menopause. The burden is huge, As you can see here, endometriosis is a chronic disease, and it's a disability, and there's over 2 million life years every year that are lost due to disability and even death because of endometriosis. So it's a very serious chronic disease. So what are the symptoms? Could be anything. Could be tiredness, lack of energy, pain, dysmenorrhea, painful periods, pelvic pain, lumbar pain, abdominal bloating, painful intercourse, painful urination, or no symptoms. Some women with even advanced endometriosis may have no symptoms, and we may diagnose the disease accidentally during a laparoscopy or during an ultrasound scan or during investigation of infertility. So I like to call endometriosis the chameleon disease. It can disguise in many different ways, and evidently it can be misdiagnosed for many years. I mean, on average, it may take up to 7 or 8 years for the diagnosis to be put correctly. So women with infertility have a 30 to 50% chance of being affected with infertility, with endometriosis. So that's fairly big. That's fairly big a burden. And of course, you understand that the incidence, the chance, the possibility of an infertile woman suffering from endometriosis is 5 times higher than the normal population. So here we can see some mechanisms. At this stage and during the day, I'm not going to go through the details, but there's a lot of ways, a lot of pathophysiological ways that endometriosis may affect fertility. So what is the effect of endometriosis on the outcome? I mean, some people in the past thought, okay, fine, someone may have endometriosis, okay, we know that. This has affected their tubes. They may have a cyst, or they may have a spot or two of deep endometriosis, but I'm going to do IVF and it doesn't matter. Well, actually, it does matter. So it is proven that implantation rates can be 16% lower in the endometriosis group. The number of oocytes retrieved can be 50% lower. I mean, we recently retrieved oocytes from a young patient, a patient age 31 with endometriosis, and she had only one viable embryo, at only one normal blastocyst at the age of 31. So lowers the number of oocytes. Interestingly, the multiple pregnancy rate is higher, and that's mainly iatrogenic because of our stress to overtake and to improve the outcomes by implanting 2 embryos, which is not always good practice, as we know. Ectopic pregnancy rate higher, that goes without saying, and this may be clearly associated, amongst other factors, with adhesions and inflammation in the tubal area. So what are the outcomes, the pregnancy outcomes? Placenta previa. I mean, when I first read that, I couldn't see the connection, but there is one there. It's 3 times higher in the endometriosis group. So even if we manage to achieve pregnancy, despite the challenges, despite the lower chances of success, pregnancies are high-risk, complicated pregnancies. Postpartum hemorrhage, 25% higher. We're talking about serious complications here, placenta previa and hemorrhage. So what are the outcomes of IVF and ICSI? So less oocytes if you have endometriomas, less total number and less normal mature oocytes. The overall number of embryos and high quality embryos, there seems to be no difference. So what are the options? How do we treat women with endometriosis? Firstly, preservation of fertility. So the fertility specialists, I mean, there are not many, not a lot. There are some, perhaps not enough, endometriosis centers, at least in the Western world. Good centers, accredited centers, multidisciplinary team centers. I would like to see more centers, including fertility specialists in the multidisciplinary teams. It seems that most centers, they focus a little bit more on surgical aspects, And yeah, they may refer to an IVF center for further management, but in my opinion, I think that a fertility specialist should be sitting in the multidisciplinary team of endometriosis centers, just the same way that a medical oncologist or a radiotherapist is sitting on an oncology board. So the dilemma is, what do we do? To me, it's very clear. I mean, when endometriosis is diagnosed, and whether this young woman and reproductively young woman is any woman after under the age of 50, I would always bring into the counseling and consultation the fertility area. And if there is a wish to preserve fertility or to enhance or to increase the family members, that's always part of the equation in managing those patients. Now, whether we do fertility preservation before surgery or after surgery, that is individualized, but definitely the fertility assessment and also fertility options are being discussed during that consultation. So what are the factors determining the plan? It's, of course, the age of the patient, their condition, additional factors, the severity and the extent of the disease, and also, of course, the severity of symptoms and in particular pain. So we would have to combine all that data and, of course, individualize through the multidisciplinary team a patient management plan. So the treatment options include medical, surgical treatments, fertility options, and of course some new emerging treatments. So medical, more or less familiar, you're familiar with most of them. Suppression of the ovaries, GnRH analogs, contraceptives, anti-inflammatories, and various other pills, which overall are not recommended for fertility management patients. Fertility treatment options. This is the three musketeers of my lab. So it's not a generic pictures. These amazing ladies ensure that our lab here at Embryoclinic is working perfectly, and I'm very grateful to them. Together with Mr. Gibbon, Dave Gibbon, who is our supervising embryologist. Hi, Mr. Dave, I know you're listening. You're always there supporting in every possible way your patients and our staff. What are the options? Pre-IVF testing and fertility counseling. Very important to assess fertility before we embark on any discussion on fertility options. Sometimes we do IVF and ICSI early, before surgery, after surgery, and so forth. We discuss the option of embryo donation if we're dealing with reproductively advanced female age, or with ovaries that have been destroyed, or with diminished ovarian reserve, or with multiple failures with IVF. Oocyte and embryo donation may always be the option, and even surrogacy option may be valid for some complex and challenging cases. So what about the surgical treatments? I mean, the surgery is important because many times, we need to alleviate patients' pains. Many times our patients have tried a lot of previous options. And of course, we need to improve that pain. We need to diagnose correctly the disease by histology, and we need to improve the access to the ovaries. Thankfully, in the last 30 odd years, 30, perhaps 35, 40 years, the minimally invasive options are here to stay, like laparoscopy. And recently, we have robotic surgery, which has improved our ability to deal better with more challenging and complex cases of endometriosis. So it's not the new kid on the block. It's been around for about 25 years. However, it seems that in the last 10 years, it seems to be expanding an awful lot, and all over the Western world. And in Europe, it seems to be becoming the most popular and perhaps the most advanced, technologically advanced option for endometriosis patients. There are emerging treatment options. I'm going to go very quickly through them because these are under evaluation at the moment. And of course, there's a lot of work being done in order to provide resources to our patients, in order to empower our patients to come forward, to demand better treatment, better management, better support, and better provision of options for endometriosis. And this is one of those examples in the Life magazine. And we were very happy to contribute with an article in the recent study, and in particular with focus on fertility. You can scan this QR code and you should be able to access more details on this magazine. So I think I've kept my time. Take-home messages: common condition, significant impact on quality of life and fertility, significant negative impact on IVF outcomes. The treatment of endometriosis in the context of fertility may be challenging, and this is where the multidisciplinary team becomes crucial. Optimal treatment is usually the combination of medical, surgical, and fertility options. Robotic surgery is the latest available technology and offers a safe and effective solution to endometriosis, with emerging evidence comparing robotic versus conventional laparoscopy favoring robotic surgery, and of course phasing out the need for laparotomy for big incisions, big abdominal trauma. And both surgical and fertility expertise are jointly required for the optimal management of endometriosis. So these are my take-home messages. I'm sure you would have lots of questions. I have the references here, so you can take a screenshot. You can look into the details. I proudly mention here that my team has undertaken the task to translate into Greek for the Hellenic patients and doctors in Greece and Cyprus of an amazing textbook by AMSO and Vataji. So I'm really proud to be able to present that, hopefully in the next webinar. And education, counseling, patient support, patient information, discussing the options. These are the messages for you to take home. And of course, the demand, you give us the drive to provide you with even better services today and tomorrow. This is my wonderful team. They've all contributed to this presentation. Dr. Manos Xidias, our bright research fellow, has compiled most of the evidence, but the rest of the team have also been very supportive to make free time for us to be able to prepare for this tonight. I'm grateful to them all. Thank you so much, and I'm ready to take questions.
Thank you so much indeed. And you are right, lots of questions are here already, and I know more of those will come. So yeah, don't hesitate. We are about to start our Q&A session. The first question we have, let me just show you this. So how do different hormonal treatments like GnRH, agonists, progestin, or oral contraceptives work to manage endometriosis, and what impact do they have on fertility? This is our first question. Thank you.
Sure. Effectively, the simple answer is they work by regulating the cycle, by either diminishing the cycle and or suppressing those areas of endometriosis. In my opinion, there is a limited place of medical management because for a number of reasons. As an adjuvant treatment. So if we do surgery and for some reason we're not able to excise all the lesions, or we don't see all the lesions, so we thought we've removed all the lesions, and that's why endometriosis is a very complex condition and disease. It's not being managed properly, in my opinion. Overall, it's considered okay, it's a benign condition, okay, it's not oncology, it doesn't have priority in the funding, it doesn't have such a huge priority in the in the government planning and all that. So many times patients with endometriosis are not really managed properly by surgery, and then they either have residual disease or the disease hasn't been diagnosed correctly, and we haven't really touched upon those areas. So we do endometriosis surgery, for example, for an ovarian cyst, and we miss deep endometriosis, which may be also present, and so forth. So these patients, 1, 2, 3, 4 months after surgery, they're still in pain. So yes, there is a place in those patients. There is a place, a limited place, but perhaps in terms of time. We can't keep them on medication forever, but there is a place until we understand which way to go. Are we going to go into preservation of fertility if they desire fertility? Are we going to go into more radical surgery in a more specialized center? Are we going to invite a world-class specialist? In my center, I don't hesitate to talk to the best in the world and some giants out there that make us dwarfs feel a little bit more important than we are. So I don't hesitate to ask for help, ask my colleagues around the globe to give me an opinion and even come over and operate with me those difficult cases. I think what we have to address is that locally as a surgeon, endometriosis is more difficult, more challenging surgery than cancer surgery. The impact of endometriosis on the tissues is worse than cancer, and this is my personal opinion after 30 years of dealing with endometriosis and cancer cases, for that matter. So the place there is a place of medical management, but it's an adjuvant place. It's not the main place. Now, perhaps until the next surgery, or until IVF, or until fertility preservation, or to gain some time if we want to give definitive treatment. Also, there may be a longer term place in older patients who don't desire pregnancy. I mean, I've had a number of cases. I mean, at the moment, I probably have half a dozen of cases of women in their late 40s who were menstruating, who had deep endometriosis, who following counseling, they didn't let me treat their deep endometriosis. They didn't let our team manage their bowel endometriosis. They didn't consent to have bowel shaving or bowel resection for endometriosis, which is major surgery. They said, okay, take out as much as you can, but I don't want a colostomy. I don't want bowel resection. And then we'll discuss. And those ladies, they have some remnant deep endometriosis, which we manage conservatively. And we're hoping that, in the next few years, perhaps this would improve without medication. It's not easy. It's not happening automatically once they hit 50 years old. I have a 52.5-year-old lady who's still in pain if we stop GnRH analog. So there is a place. That's the bottom line. There is a place, but I think as a team we have to discuss firstly with you. We have to understand you. You don't have to understand us, but we have to understand you. That's my primary focus and aim of what you want, your wishes, your beliefs, your red lines, and then of course tailor our treatments towards your individual needs.
Sounds great. Thank you so much indeed for the first question and your help with that. Now we will go to the longer question here. As you can see, there are some details. Let's have a look at this, okay? So I got diagnosed with endometriosis stage 3 and adenomyosis. Additionally, my husband has teratospermia. I had 10 transfers. You can see all the details here as well. So let me just go here. So basically, I'm starting with this Rieco for 3 months, but I'm pretty sad I'm losing hope. What would you recommend doing? Additionally, immune system check, microbiome, already have been checked and are fine. What would a foreign clinic, I'm from Germany, would do to increase the possibility of getting pregnant? 35, 4.7 AMH. Anything you can add here?
Well, firstly, thank you for sharing your case, and congratulations for being so brave after so many attempts. You're still on the game, so I feel this is awe-inspiring, and congratulations. I mean, firstly, if I did IVF with your eggs, I would definitely do pre-genetic testing. I think after so many transfers, at least you must ensure that you have genetically normal euploid, as we call them, embryos. So that's one factor. So factor number 2, just ensure that I have no problems with re-echo, although I don't have huge experience. I don't think anyone in the world has. It's a new drug. So I would have no problems using it for a few months. So firstly, ensure good quality embryos genetically tested. Number two, ensure that the pelvic anatomy, the pelvic condition is reasonable. So, proper ultrasound scan, 3D, 4D ultrasound scan, hysteroscopy, maybe a tubal test just to exclude hydrosalpinges, to exclude endometritis. I would like to make sure that the uterus is normal as well and the surrounding area. So if that's the case, yeah, definitely microbiome. I'm not sure about the immune system check. I mean, I think most people would probably dispute this a little bit. I wouldn't disregard it 100%, but I would probably leave it to the end. Endometrioma, definitely. And then, if I have ensured that the endometrium is reasonably good, if I have excluded hydrosalpinges, if I have good quality euploid embryos, I would keep going. I mean, maybe before the implantation, I would disconnect egg collection from implantation because I would probably like to suppress you with GnRH analogs for definitely a few weeks, if not a few months, prior to the embryo transfer in order to reduce the inflammation prior to the embryo transfer. That's what I would do as the next phase. I hope
Okay. Thank you so much, Larissa. Let us know if there's anything else. As always, you can still type your questions in. And now we'll go to a bit of a shorter question. What is the reason for poor quality of oocytes received by ovarian picked up by endometriosis?
Sure, there's a lot of reasons. I mean, I'm not going to go into the detail, but one main reason is that endometriosis itself is locally damaging via many mechanisms. The most obvious mechanism is the inflammation. Damages the primordial follicles, damages the ovarian reserve, eats away, destroys the normal ovarian, the normal ovarian tissue, the normal ovarian function, which is a production of oocytes. Secondly, the surgery may harm as well. Unless you are very meticulous with your surgery, unless you're very respectful with the oocytes, you're very shy. We need to be very shy with the diathermies. We shouldn't be cauterizing the ovaries very abundantly when we do surgery. So all these factors affect not only the number, but also the quality of the eggs. So these are the clear mechanisms. And that's why the overall numbers of oocytes retrieved is very small. I mean, it's very clear also that, when you see the histology, many times you see the histology of an endometrioma, and together with the endometrioma, you see a few follicles, a few healthy ovarian tissue follicles that have been removed as well. So, think of a flower that's eaten away by bugs. So, you either, trying to kill the bug, sometimes you destroy the flower as well. So ovaries can be very, very robust, but they're also very sensitive. So I think it goes without saying that the number, the quality, and the quantity of the eggs is diminished with endometriosis plus minus surgery. Now, if there is endometrioma, there are clear guidelines which are not always being followed. I mean, I don't, for first surgery and the first diagnosis, to be honest, I don't sit around with endometriomas for a very long time. If I'm fairly convinced with the ultrasound evidence that can be as accurate as perhaps 85, 90%, if I'm convinced it's endometrioma, it's growing, it's 3, 4, 5 centimeters, I'm not very shy. I don't hesitate to do surgery, not only in order to evaluate the rest of the pelvis, but also to remove the endometrioma when it hasn't done a lot of damage on the ovary, and also to make a diagnosis, because although rare endometrioid type ovarian cancer is something that all of us have seen in young women in our attempt to be conservative, sometimes we have risked their lives, and I don't want to be faced with this again.
Okay, thank you. There's another question on PRP actually, so whether it can help with the quality of oocytes. Anything, a few words you can add on that? We will talk about it. We will have a webinar on this, of course, as well.
I can't say about the quality. I mean, the answer is I don't know the clear answer. It depends. I mean, PRP is not for everyone. It's not, it's not a panacea, as we call it in Greek. It's not a solution for everything. It sounds perfect. It sounds clever. Theory behind it is fantastic, but the evidence is not there yet 100% to support it. There is more evidence on endometrial PRP, on the effects of endometrial PRP in improving implantation than there is evidence on the ovarian PRP. I think we ought to acknowledge that. On the other hand, the technology is there. We can do it. It's not terribly difficult to do it. It's not very challenging. It's not very risky. But on the other hand, I think we have to counsel our patients very carefully as to the expectation they would have. Yeah, maybe in the context of, I mean, yesterday actually I had a lovely patient from Serbia with endometriosis affecting her tubes. She'd had a couple of surgeries in the past. She nearly lost one ovary. She had a streak of ovary on one side and perhaps 30% of ovarian tissue on the other side. Massive adhesions. It was about 2 hours to get onto her ovaries. I regretted I didn't do it robotically because of cost saving, elements. I did it just with conventional laparoscopy. So on that lady, once we've cleared the endometriosis, removed the tubes, removed the adhesions, yes, I did PRP on the ovaries as well. She's only 35, so I thought it wouldn't harm, and I would of course monitor the outcome and hoping that it would make a small difference. Now, whether it's the quantity, the quality, we don't have scientific evidence yet.
Crystal clear. Thank you. Indeed. Short question from Sarah. How long after excision surgery is it okay to do frozen embryo transfer?
Depends is the answer. Depends on the severity of the disease, on the extent of the surgery. I would hope it's minimal access surgery, keyhole, either conventional or robotic. Depends on how you feel and all that. I mean, if everything is normal, if the recovery is good, I'm very happy to go within 6 to 8 weeks. And also depending on whether there's residual disease, whether there's inflammation, I would like to downregulate. I think a reasonable plan would be to downregulate. I would downregulate anyway. Prolonged downregulation is something I really like, to be honest, not just for endometriosis, but for adenomyosis as well, which very commonly is there. Sometimes we see it, sometimes we don't. But I think we have to presume that even if we don't see it, we have to presume that there is likely adenomyosis, even mild adenomyosis is likely to be present. So yeah, I would downregulate for 6 to 8 weeks, and then go for embryo transfer. Okay,
thank you. I will show you the next question here, okay, from Rebecca. Sorry. This is the one. So low ovarian reserve with stage 2 endometriosis exists 8 weeks ago, might diffuse adenomyosis, trying to conceive over 2 years. What are my options given long group suppression is a concern with low ovarian reserve?
Yeah, I mean, I wouldn't worry too much about the ovarian reserve, the effect of suppression on the ovarian reserve. I mean, suppression is like makeup on your face. I mean, it's there as long as you freshen it up, as long as you keep, adding on. And if you wipe it out, it's out. So I wouldn't worry too much about that. If you're thinking of IVF soon, then yeah, you can have suppression for a bit of time. If you're not thinking of IVF soon, I would probably do egg preservation, oocyte preservation sooner rather than later, because the effect of age on the genetic dynamics, on the quality of the eggs, if you like, is there, whether they're suppressed or not. So if I'm not considering IVF soon, I would proceed with stimulation and oocyte preservation, and then I would go back on the ovarian suppression.
Okay, thank you. Now let's go to the question from Helen. So what are your thoughts on utilizing nanoparticles for fertility preservation? Can they enhance existing methods and improve outcomes? Have you been involved in research related to nanoparticle-based therapy for endometriosis? How do you see its potential impacting managing this condition?
Thank you, Helen. You're very well read. As far as I know, I have no experience, is the clear answer. And my understanding is that it's only being used in the context of research at the moment. So I don't think there's clinical indications to use it, on our day-to-day patients at present. So, let's watch the space and let's hope that they will give us some evidence to be utilized clinically.
Okay, thank you, Chris. Now we will go to the next question. So I had 4 failed implantations. MRI detected endometriosis and adenomyosis. Are they both can affect fertility? I have no pain, other symptoms. With steroid treatment solve the implantation problem. What else to do?
Sure. I mean, failed implantation can be embryo factor or endometrium factor. So, my advice would be the same as I gave to a previous attendee. If you have more IVF, make sure that you have PGTA. I mean, we don't, to my mind, after failed implantations, 2, 3, 4 implantation failures, I think PGTA is indicated, regardless of the age, for 2 reasons. One is that diagnostically it's giving us information about the embryos we're transferring, and we're not in the dark. And secondly, it has been proven, actually, there's an amazing research paper published recently that if we test genetically the embryos, then the age of the woman doesn't really play much importance in the success rate. So, we eliminate this age factor by using euploid embryos. So that's what I would suggest.
Okay, thank you. And now we will go to Yetunde and her question. I had Diprolapron 11.25 milligrams 5 months ago for prepping for fibroid and endometriosis surgery. I still don't have my period back. I am anxious to start my next IVF. What is your advice? 41.
Well, I mean, you can presumably you had your surgery. Personally, I don't particularly like long-term GnRH analogs before. Definitely, I don't like it before fibroid surgery, but anyway, that's personal preference. You can very clearly solve the mystery by having a scan and a blood test, hormonal blood test, in order to understand what's happening with the hormones and why are they being blocked. I mean, there is a possibility that perhaps your AMH was very low, even before surgery and before the downregulation, and maybe for some reason now it takes a little bit of longer time to recover. But, AMH, FSH, LH, estradiol, progesterone, thyroid, and prolactin testing should be enough to help you understand what's happening.
Mm-hmm. Okay.
Caroline, one more question, please, because I think there's a storm coming out, and I will have to secure the clinic. I'm sorry.
It's all right.
It's a little bit unstable now.
Of course, we will go for our final question, but of course, we have all of your questions, and we're happy to forward them, okay, to the team as well. Okay, let's have a look. This is the question. So I had frozen eggs, but they didn't survive. Also, I had 2 IVFs, but with empty follicles. I had only 1 time IVF with blastocyst, but didn't get pregnant. I had 6 operations, 2 times hysteroscopy. At the end, I was 2 times on IVF with donated eggs, but no success. I'm 43. What else can I do?
Hi, Moika. I'm sorry to hear that. I mean, I think egg donation IVF is the way forward. Definitely. I mean, you're on the right path. And that takes away from the equation the embryo quality. I would expect that, with the neck donor I would go for a very young donor, like in their 20s, and ensure top quality blastocysts to ensure top quality embryos. And then I would just concentrate on the uterus. So, hysteroscopy, microbiome, high resolution ultrasound scan for adenomyosis, myomas, and endometriosis, and perhaps downregulation for 6 to 8 weeks prior to embryo transfer. And do not forget the tubes. Do not forget to exclude high-dose salpinges, because I see it very often. I mean, that amazing patient I had yesterday has had multiple embryo transfers with abnormal tubes, and there's no hope there. I mean, think of the tubes as a source of infection. It's like implanting a beautiful new tooth next to a rotten one, so it's not going to take. So yeah, make sure your uterus is normal. High resolution ultrasound, hysteroscopy, and hysterosalpingography should be able to ensure the normality. And then, of course, very tight protocols, very tight monitoring of the embryo transfer process, perhaps a little bit longer use of estrogens, monitoring of the levels of estrogen, progesterones, and of course, getting the best person to shoot the penalty, which is the embryo transfer.
Okay, thank you so much indeed for answering the final question, as Dr. Tsakos already mentioned, but again, don't worry, we will definitely simply forward the questions to the team, and I'm sure they'll be happy to help you out with some more details as well. I know that it's required always to give a proper answer. So thanks a lot, everyone, for your time, for your questions. Dr. Tsakos, always a pleasure to have you. We will see each other quite soon, but of course, remember, Dr. Tsakos will definitely be back for some more webinars, so stay tuned. There's some more webinars coming up. Also, next Tuesday, on Tuesday, we will be back with another topic too. So thank you, everyone. Enjoy your evening and see you soon. Bye.
Thank you, Caroline. Thank you, everyone. Good night.
Bye.
Bye.